Welcome to our latest episode of the Lebanese Physicians Podcast. And today, this is episode number 72 of the podcast, which we'll be discussing in it improving access to primary healthcare in Lebanon, especially in the era of the economic collapse and crisis. And our guests today are Rouba El-Khatib, who is primary health program manager at the Agence Francaise de Developpement, and Madhuri Severgnini, who is actually the health program manager at the EU delegation in Lebanon, and both of them are involved in donations and donor issues in healthcare in Lebanon. And this episode is co-hosted by Dr. Vlad Chaddad, who probably everybody met in a previous podcast. Vlad, you can introduce yourself in a bit, and then Dr. MohammadAli Jardaly, the famous, he's been co-hosting the podcast with us. So Vlad, do you briefly want to introduce yourself too?
Yeah, so I'm Vlad. I'm a medical doctor. I've been in the health, humanitarian, and development sector since I graduated 2014. My experience is mostly in the Middle East. I'm currently the regional health advisor for IRC in the MENA region.
Great.
Thank you.
All right, and thank you, Rouba and Madhuri, for being on the podcast.
Thanks for having us.
So I'm going to ask this question for Rouba, but Madhuri, you can feel free to chime in too. So how was primary healthcare in Lebanon before the era of economic collapse, and was it available to all the population?
Okay. So I'm gonna be speaking as a Lebanese before speaking like on as a health project manager for AFD in Lebanon. So as we know that in general, the Lebanese healthcare culture has always emphasized the tertiary care above primary healthcare. So PHCCs were always overlooked. Primary healthcare was overlooked. PHCCs were always considered for the poorest, mainly refugees, domestic workers. So rather than strengthening the PHC, the Lebanese health system empowered private hospitals, mainly by covering 80-90% of patients' bill through the NSSF. So over the time, private hospitals flourished, and public institutions, be it primary healthcare, public hospitals, they were like really neglected in terms of staff shortages, budgetary constraints, etc. So although you asked me if it's the access, the primary healthcare centers, they are like equally distributed across the country, but they remain underdeveloped with no provision of basic diagnosis, imaging, and testing. So patients still have to go to hospitals to require diagnostic tests specifically for emergency. So if I can describe it, there was like really some very bad perception or reputation around primary healthcare centers. But now I think with the economic crisis of 2019, this perception has changed. And primary healthcare centers, they provided the proof that they can increase access to health, improve the overall health access, control illnesses, decrease the cost, and keeping the hospitalization as the last resort.
Yep. Vlad.
Yeah, thank you. Thank you, Rouba. Shall I ask the second question?
Yeah.
Yeah. So it's a question for both of you, Rouba and Madhuri. So what has been the role of the EU and the AFD before and after the crisis, and how have you been promoting the primary care in Lebanon? And maybe describe how you both organizations invested in the primary care sector in Lebanon, like a bigger picture. Maybe with Madhuri.
Maybe I can start. Okay. So I mean, thanks for the question. I mean, from our side, from the EU delegation side and the EU institution side of things. So actually the EU became involved in primary health and health in general since 2018. We were not involved in the health sector before. And basically what made the EU become active, if you want, in the health sector initially was the Syrian refugee crisis in Lebanon. So we had a political line to follow as well. which was basically linked to supporting the government of Lebanon with the additional load and people that would be needing to access these services while being hosted in Lebanon. So this is essentially Syrian refugees. And so basically all of our basic services funding, which in this episode we're discussing health, but it goes to say for education and social protection as well. We became involved with this, if you want, for this reason. So before the presence of Syrian refugees in Lebanon, we were not active in the health sector. And I mean, this is changing, of course, nowadays because the crisis is worsening, it's impacting everyone. But I think it's important to be reminded that the initial reason for us to become involved in health was indeed the Syrian refugees. And the choice, if you want, of supporting a primary healthcare system was a little bit linked to what Rouba was saying, is like when we first became involved, there was a very empowered private sector, if you want, within hospitalization, specifically looking at tertiary care. And essentially, when the refugee population started coming to Lebanon, it was mostly women, children needing access to basic services, to deliveries, to antenatal care, to children immunization services, to try also to compensate for the crowded living conditions that most of the Syrian refugees were ended up living in. So you wanted to prevent disease outbreak, you wanted to make sure that children were vaccinated, that people had access to medications, because in general the population was one which was more vulnerable and poor than the Lebanese population. So the entry point and the access for us was really primary care. If we supported that system and that sort of network which the ministry had set up through the primary healthcare centers, it was a way of making sure that these primary healthcare centers were receiving funding and support so that they could continue to provide services to anyone who needed access with kind of a universal health coverage vision to our programs. So that's why basically, we became involved in health because of this reason. And then we chose the primary health care to really push on preventive care and promotion and try and basically stop people from getting sick to the extent that then they would have needed hospitalization, considering that, they were a more vulnerable population as well. So I think that's a little bit the background to our involvement. Of course, it's changed since. I mean, especially since the last two years. I mean, the space of prevention and health promotion has stayed, but we see the number of people that are reaching our centers, as Rouba is saying, is a lot more higher than it used to be. There is a change in behavior and perception that these centers really are offering quality care, and anyone can have access to them. So it's changing a little bit, but yeah, as a reminder as to why at least the EU and I think AFD has similar reasons that Rouba will now go on to explain. But this was a little bit the thinking behind it. And yeah, I mean, that initial investment is somehow we're hoping will pay off during this crisis and the future, so that a more permanent behavioral change towards going to seek health as a preventive and promotive means, and not just when one is really sick, we're hoping will stick through that investment that was initially made by the donors in 2018 with the Syrian refugee crisis.
Maybe thank you, Madhuri. So maybe from AFD side, it's quite the same. So actually our intervention within the healthcare sector, we started in 2019 supporting public hospitals, knowing that in Lebanon, AFD mandate is to support the public sector, being on different subsectors, being on health, education, etc. So we support the public, the national strategies and institution. But actually our kind of working, of our way of working has changed. So AFD, as a development agency, we are used and our mandate is to invest mainly in infrastructure and as development bank. Now, actually, we are shifting and we are more investing in human capital, being healthcare workers, being patients, supporting patients well, etc. So we switch from like a public policy dialogue to funding operating costs. Actually, this is what we're doing right now. So we had also to adapt our tools, and actually we were a bit like obliged a bit to try and change our financing tools. So we shifted from big loans to working with the ministries of public health in the case of the health sector to mainly grants channeled through international NGOs or association. So actually, it's not really our mandate and it's not really our role as development bank. So what I can say that we are really operating in a very unusual way a way that is very particular and exceptional to the Lebanese context. So actually, we are accompanying the collapse of the system, and we are trying as much as we can to slow down this collapse, the system collapse. So this is not at all our way of working, and we didn't choose to work on primary healthcare, on health in general, but now we are shifting from more than investment, more on assisting on basic services and basic social needs. So yeah.
Maybe I can just add just one thing on what I was saying initially, how the EU health program and the basic services investment started in 2019 and was around before. The idea there was also that Lebanon was, an upper middle income country. It had its own government, its own ministries, its own system to kind of provide health services for those in need, right? So there was no need for this external aid, and the external aid was needed to support an additional population which was external to the Lebanese population that needed to seek access. But this is why basically before 2018, there was the EU development cooperation focused on other areas like security, like trade, like economic growth, because the country was considered an upper, middle income country. People had insurance, people were able to, it wasn't considered like a country in crisis, in need, where basic services needed to be provided and subsidized by external aid. So just a point to add there.
No, this definitely makes so much sense. Before the multiple crises of 2019, it was not just the economical crisis. The economic crisis also coincided with the COVID crisis and then the Beirut blast. So it's one crisis after another, and the entire healthcare system has completely collapsed. So before the crisis, we don't have exact statistics, but 30% of the Lebanese had private insurance, 30% had insurance through the NSSF, through the Ministry of Public Health, and basically after the multiple crises from 2019 onward, all of that has been decimated. We don't have exact statistics right now, but the majority of the Lebanese have been plunged into poverty and have no access and no coverage of healthcare whatsoever. So in terms of strengthening the primary healthcare center before 2019, really the Lebanese were able to get by and to focus on the private sector, but the ground and the game has shifted completely since then, whereas the majority of the Lebanese cannot afford the private sector. So it's really timely that we have all this external support to support the PHCC, which is open to everyone in Lebanon, whether Lebanese or Syrian refugees, and we also have the Palestinian refugees and migrant workers. So it's really multiple populations residing in Lebanon who are able to access this. And as someone who did family medicine training in Lebanon, I've had the privilege to work in multiple and train in multiple primary healthcare centers, and I was able to see the shift in terms of the funding and in terms of the shift in perception and access of patients really before 2019 and after 2019. Like you can see a clear demarcation. And really, I think the primary healthcare center and the public sector itself, especially during the COVID-19 pandemic, was able to pull in its weight and was able to do amazing work that was similar to and shouldered what the private sector was able to offer. So it's really great to see all this external support to the primary healthcare system in Lebanon. And this ties us to the role of the MOPH, right? Because like you said, before 2019, Lebanon had a active government with a mission and vision, but how has that changed after the multiple crises of 2019? And are you supported by the MOPH in your mission? And who are your partners on the ground?
You want to start, or should I start?
It's okay. Go ahead, and I will continue.
So in terms of how we work with the MOPH and how we share visions and programs and how we implement, I mean, absolutely. I think one of the conditions, if you want, of our aid, both internally for ourselves, but also with respect to the Lebanese government, is to have a dialogue and to have a coordination mechanism, which is strong. Because essentially what we're trying to do with our programs is, of course, to provide services to those who are in need, but it's always been, we are not humanitarian actors, which might be a bit confusing in this context, because what is humanitarian, what is not humanitarian? can be confused in contexts like Lebanon and protracted crises and everything. But essentially, we are development cooperation actors, which means that, of course, when we work in these basic services, we are there to respond to needs and to provide services, but always with a kind of system strengthening approach. In our case, a health system strengthening approach. And, you know, in order to achieve health system strengthening, you need to work within a system rather than set up a parallel structure. So all of our assistance has always been coordinated and, you know, worked with the Ministry of Public Health. So in designing our programs, in deciding indeed that primary health care was going to be the point of entry, and trying to identify exactly how our aid was going to be implemented, which centers, how the payment mechanisms, the packages of care to be supported. So from our side, and again, Rouba will speak on behalf of the AFD, but it's always been very much coordinated with the ministry. Because of situations which are much out of my own hands and out of Rouba's hands, we are unable to provide direct funding to the Lebanese government, because this there's, you know, reform programs and political lines that are supposed to be respected. And at the moment, the IMF program is indeed the carrot and the stick, if you want, that we're trying to push through with the Lebanese government in terms of reform for more substantial aid. So actually our aid, even we are coordinating with MOPH, but we are unable to provide direct funding to the government and provide public sector spending. So indeed, then we have partners on the ground who are implementing the programs that are designed together with us donors and the Ministry of Public Health, as well as other big UN agencies that are active in Lebanon, and, you know, the whole health sector as a whole. So currently we work primarily on our primary healthcare program is implemented through INGOs, International Medical Corps and Première Urgence Internationale, who they in their part, so we are contracted with them, but they in their part support a network, 60 primary healthcare centers all over Lebanon who are run by independent NGOs and associations. So they are our partners as much as, you know, the other UN agencies and INGOs with whom we work with. And they are the ones essentially delivering the care and making sure that the quality of care is there, that payment mechanisms are respected, that people who are supposed to be have their services subsidized, indeed have their services subsidized, that there's equal treatment and equal access to anyone needing care with a universal health coverage approach at primary healthcare centers. So it's all coordinated with government structures, because as I mentioned, we're trying to support health system strengthening and to have sustainability once we will no longer be funding these programs, so capacity building and everything. But in terms of actual implementation, we work with basically partners on the ground, which are supporting the implementation of these programs. We are unable to work directly with MOPH.
Rouba, Rouba, you're muted.
Yeah, I'm sorry. So I'm just saying it's actually specifically on primary healthcare. I think AFD and EU are the main donors within this sector or this subsector, and the idea is actually for AFD in general is not to create a parallel system or like a fragmented system. Already the primary healthcare system in Lebanon is fragmented, so we are not here to increase this fragmentation or to even create this parallel system that at the end, we will be accountable of creating the system, and we don't want to be faced. We had this issue of, okay, if AFD drops out from this hospital, we will not be able to continue, and we will be obliged to close the hospital. So this is actually the least that we want to create, this dependency to international donors. Unfortunately, as Madhuri said, we're not allowed at this stage to finance directly for political reasons in the MOPH, but the idea and we urge, and it's a condition for us to grant funds for the NGOs. In our case, it's also Première Urgence, Médecins du Monde, and also we insist on working with local NGOs like AML, etc., in order to hand over this project to the MOPH one day, inshallah, when the situation is a bit better. But the idea is we are not here to replace the MOPH. This is very important. We are here to support, and we are not here to take the role of the state. This is why actually we are implementing the national strategy. We have the buy-in of the MOPH. We have so actually they are accountable, they are responsible of the results of their own strategy. And this is very important for us. And now I think we have like a good minister that there's a national strategy, there's a 2030 vision that we are fully aligned with, and we are trying to implement as much as we can through our partners, awaiting for, like Madhuri said, the IMF, and the day we will be able to work again and give grants to the MOPH.
Yeah, I mean, I'm sure there's like limitations in different countries in terms of working as donors in these countries. I mean, some countries don't have a government, some countries there's war when you're going into these countries, and I'm sure there's limitations in Lebanon per se, because there's a lot of political, I guess what we could call instability maybe, or that affects you or limits you in terms of delivering the care that you want to deliver. But it's good that you're working with the MOPH to try to implement a national strategy. So I assume that the NGOs that you're working with, and I think Vlad works for an NGO too, and he can comment on this too, but the NGOs that you're working with are vetted, right? Are they vetted by you? Are they vetted by the MOPH? Or how do you vet these NGOs that you work with when you decide that you're going to donate funds to these NGOs? Maybe Rouba, you can start with this, and then Madhuri can follow.
Okay, so in terms of vetting, the decision is eventually and mainly from our side, but we always have the MOPH and specifically the Department of Primary Healthcare with us within the selection committee. So they have the right to vote and to choose the consortium, mainly the consortium of NGOs that will be handling the project. And maybe one point here, it is very important that within this very volatile political context, we maintain a very good relationship with the ministers eventually, but also we have a very solid relationship with the departments, being primary healthcare department, hospital department, because these are the people who will eventually stay, and we will be able to continue working with them beyond political interference and political changes. So you asked about limitations and challenges. Political dialogue and diplomatic dialogue, if you want, with public policies and the expression of needs, it's very challenging for us. So we have different political vision within the sectors, so we have big discrepancies. We don't always have a strategy. We have, as AFD, as Development Bank, we have also overarching objectives, mainly SDGs and indicators for which we are accountable, and this is actually a kind of limitation and a challenge. And as I said, financing tools. So now, with grants, we are very limited with the amounts. We are very limited with the mandates. So loans give us eventually more flexibility. Also, in the absence of a banking system, the collapse of a public sector, we have the middle class who is disappearing and who is turning. So we have this huge and massive movement from the private sector to the primary healthcare sectors to receive this medical case. This is actually also a big challenge for us in order to enter the primary healthcare eventually, to absorb this toll on the public institutions. So sometimes we feel that we are a bit like, as I said, working in like a chronic crisis now. We can say it's not like an acute crisis right now, and I can say that sometimes we feel like we are really in a situation of powerlessness. So yes.
Vlad raised his hand.
Over.
Oh, sorry, Vlad, I didn't see your hand is up.
Yeah, I just wanted also to highlight one thing that Rouba touched upon on many levels. It's communication and coordination. And Lebanon, I mean, since the time I've joined the health sector in Lebanon, it has shown a high effectiveness and professionalism. So this sector, they meet on a monthly basis. You have representatives from different donors, different NGOs, international and local, and also the presence of the Ministry of Health. So the fact that we are all talking about same problems. We can find different solutions, but as well as I can say to you that, for example, whenever we are choosing a place or we are want to target, a new place, we always coordinate with the local health authorities, but as well as the Ministry of Public Health. So we're always on in good relations in terms of communication, because we want to also avoid duplication. So we don't want also to have like two INGOs working a lot near each other, So this is also a smart way of having a more cost-effective project. As Rouba said, that worldwide, we are seeing also decreasing funds, for our projects. So we need to be smarter in using those funds. So people are getting through good consultation, good results, and we'll see what the future will hold us. Thank you.
No, maybe just to add a little bit on basically challenges and limitations also as international donors trying to put on, programs that are not creating parallel systems, that are doing system strengthening, and that are trying to ensure some continuity beyond, and something beyond just financing, right? And I think a big limitation that we have nowadays is, as Rouba was mentioning, the collapse of the middle class. This also includes the collapse of purchasing power of, civil servants and people working within ministries and within government. So we rely on these national structures to coordinate and to work with, to ensure that we're setting up a system, that we're, increasing technical capacity and ensuring that, the technical support that we are providing is going to be in the hands of people that are staying, beyond our temporary support. But then at the same time, we see these government structures completely collapsing, and our government counterparts, our civil servants, unable to come to the office due to, fuel crises and salaries which are no longer competitive and enough for them to actually have a decent living. So I think this is a huge challenge. So basically having a depleting public resources with whom to actually have this exchange. And that's both in terms of people that are currently working with ministries, but it's also, the freeze on hiring of new public servants, which means that when people retire or when they leave their jobs, there's no replacement. So we have entire departments within ministries which are understaffed and people are not around. And I think this is, maybe we oversee it sometimes, but it's a huge challenge for us. And it's a very difficult one to overcome, because again, the solution doesn't really lie with us. It lies with much wider reforms that need to happen. It lies with, a collapsing economy and things that really go beyond the health sector, but they affect the health sector a lot. And then I would also say that the currency fluctuation is also a huge challenge for us, because we are donors. We are paying our projects, if you want, in this hard currency, but from one day to the next, what our currency can actually buy and purchase in terms of services, in terms of paying salaries, or not paying salaries within ministries, but even paying salaries of people on the ground in our NGOs, changes all the time, right? So understanding what really is the value and the purchasing power in a situation where on a daily, okay, now it's a little bit more, if you want, stable. But I remember when we first started, especially in 2019, when we first started some of the programs, we designed a whole payment mechanism based on a $1 to 1,500 Lebanese pound exchange rate. And once our contracts were signed, what happened. So now we are still operating on a system which is somehow fictitious, but it is what it is. So I think that's a major challenge, the collapse of the currency, and trying to understand really that the purchasing power is a problem.
This makes sense. And to anyone who's working on the ground, the challenge of the volatile currency, and sometimes from month to month, is shifting by up to 50% at one point in the summer, and then you have a plateau, and then it's ridiculous. Honestly, you cannot explain it unless you live it.
And no one can predict it, or no one knows. From one day to the next, it's just,
even during the same day, it's ridiculous to say the least. I want to just touch on something that Rouba talked about earlier in terms of not being in an acute crisis, but being in an acute, prolonged, multiple crisis, and being in just defense mode and just trying to respond to what comes ahead. Do you see yourself being involved on the long term, and how do you anticipate this transition in terms of the self-sustainability goals and in terms of achieving this self-sufficiency? And Vlad touched on it, and you touched on it in terms of the donations decreasing, not just from the EU, but elsewhere. How do you see this moving forward in the future?
Maybe I can start.
Yes.
From AFD side, actually, we don't have now a vision beyond 2023. So our current project is ongoing up until 2024, but then we really don't have any vision on the available funds that we will have for Lebanon. So what is sure, we will not stay in this mode of crisis response and firefighting. So as Madhuri said, we're not at all humanitarian actors. And our mandate now within our project, it's really to work on, I'm not gonna say long term, but maybe medium term in Lebanon, while having a small envelope to respond to unexpected crisis. But the idea is to keep the cap on the medium term. So we will not be like working like in the way that we are doing now. So actually, and as Vlad said, crises are multiplying, priorities are competing. So specifically with the Ukrainian crisis and others, so resources will not be the same, and Lebanon will not be the top priority, unfortunately, but it's the reality. So I mean, it's the idea. It's for Lebanon. Lebanon must find its own solutions to recover. And if you ask me, I do not anticipate the self-sufficiency in a system that still pay, that now the idea they will pay the salaries in dollars, while its tax revenue is still on LBP. So the only way out, it's the achievement of reforms and the IMF for us in order to achieve our intervention and our implication in Lebanon. So traveling back in time to strengthen primary healthcare in Lebanon is, of course, now quite impossible. And that means that now we need to work with the available resources and proceed with a radical reform in the healthcare system. It's the only key to preserve the right to access to health services. This is the only way we see it right now.
Madhuri, what are your thoughts?
So basically very similar to what Rouba just mentioned. So we became involved, as I said earlier in the introduction, as a response to one crisis, which then developed into something else, and ever since has gone through a couple of other mutations. So our sort of midterm, long-term vision is we are involved now in primary health in Lebanon, and until more or less 2026, we will continue to have programs and to have projects ongoing. But we entered with a very specific crisis we were responding to, and the intention is to basically eventually phase out. It's not to be here forever, and it's not here to basically subsidize the healthcare system for Lebanon forever. So as much as possible, integrate, system strengthening and support the structures that are in place now, but eventually, as all the things that Rouba just mentioned, so competing crises and mandates in terms of who is really supposed to be doing what, and really the government of Lebanon should be responsible for providing the services for health, but also for education, social protection, all basic services for its own population. So we're here to kind of fill a gap for now, but not absolutely in the long term. And this is also more legitimate, again, because we are not humanitarian actors. We are here for development cooperation. So the situation that we are in now is a little bit tricky. So let's see what we're able to achieve from now until 2026. But beyond that, there is no guarantee that we will continue to be involved in the sector.
Right. I mean, I agree. Without government reforms, it's going to be hard you cannot play the role of a government to improve vital health sectors and the Lebanese economy. It has to be the government who does that. Which brings me to a couple of more questions, which is, one is, what is the current approach? Does the Ministry of Public Health have a current approach to primary healthcare? Like, what's their approach to primary healthcare? currently, or is it just an approach that is in conjunction with the donors, but there's no like set approach, I guess? I don't know. Does Madhuri, do you want to start?
So I think, I mean, there is what has been an approach to primary health care. We are now a little bit of a critical juncture where with the publishing and the endorsement of the National Health Strategy earlier this year in January, which really put primary health care back at the center of the strategy, if you want, of the current minister, which you can argue before wasn't the case, because as Rouba was mentioned in the beginning, the whole Lebanese health sector was kind of structured around costly and very specialized tertiary care and less so on primary. But now that we are at a critical juncture and a crisis point, we see that the MOPH budget is basically worth a tenth of what it used to be worth. And we see that an increasing number of people are actually in need of the basic care, because people can no longer even go to private pharmacies to buy their own medication. They're going to the primary healthcare centers where medication is given out for free or at least a very small fee. There is really like an alarm bell, I think, has rung, and at the highest level, we've realized that actually primary health care needs to be at the basis of any healthy healthcare system. So now that this was kind of introduced as a concept within the National Health Strategy, again launched in January, the ministry then took it under his own initiative to develop a specific chapter which was going to deep dive at primary health in the development of what should be a primary health care roadmap, which is supposed to be a vision and kind of mission and an overall document to lay what the primary health care vision for the government of Lebanon is. And that's, keeping in mind principles of universal health coverage and basic care, and also human rights, right? Like we're all human beings, and I think access to basic health care is a basic human right. So let's say that there is good impetus and good motivation to really put primary health care back at the center. I think the part which is more tricky, I mean, now with the ongoing EU and AFD funding, we're implementing a sort of approach to the provision of primary health care, which is going to continue. And at the same time, the government is also looking to now use a World Bank loan to also implement a primary health care program with a slightly different payment mechanism, but following the same protocols of care and benefit packages, which are going to be expected to be provided at primary healthcare centers. And eventually, I think the idea is to see which ones of these programs is better performing and more efficient in terms of quality of care and also in terms of, financing, to then lay out basically this vision and this primary healthcare roadmap to define what primary healthcare would look like for Lebanon going forward. I think what is more tricky is for the government of Lebanon to find its own internal funding to really support this idea that primary health care needs to be put back at the center of health, of the health system, because it's one thing to develop documents and have the good intention, but it's another thing to actually put in your national budget on a year-to-year basis a budget line which is dedicated to primary health care, which up until today we have not seen. So even before the crisis, basically the majority of the MOPH budget was going to subsidize costly hospitalization bills for people that were not covered with private insurance. And all the primary healthcare system was getting was some sort of in-kind medications and in-kind vaccinations, which the government was actually also relying on international aid to provide. But that was basically the contribution of the government, medication and vaccination, but no actual funding to primary healthcare centers to be able to provide consultations and pay their staff and provide these services. It was all up to primary healthcare centers to basically find their own sources of funding. When international donors came in, there was of course a much bigger incentive for primary healthcare centers to give these services, because we came following MOPH protocols. We made the payment behind the scenes. I mean, not behind the scenes, but you know what I mean, like in the background. Now, if this intention of MOPH and the government is really to put primary health care at the center, then I think we need to begin to see that financial backing and internal domestic resource mobilization to really increase the government revenue to primary health care, and not just an intention, because essentially health services, they cost and someone needs to pay. So yeah, I think that's the biggest challenge of MOPH at the moment.
Right. And Rouba, do you agree?
Yeah, definitely. Just want to summarize the MOPH, they have the minister, he has the will, but I'm not sure that he has the means. So so the will is there now. That I mean, the budget of the primary healthcare within the MOPH budget, it doesn't exceed more than 3%. So it's really like peanuts. So it's nothing. So for us, for the Minister of Public Health, I mean, the challenge now, it's really to have the I don't know, so still taxation or anything that can secure funds to the MOPH and to be like really allocated to the budget of the ministry. But I think one challenge that is still remaining within the PHC, it's the awareness. It's I think that this component is still lacking, and whenever the MOPH lifted the subsidies on medication without preparing the ground and preparing people on the availability of services of medication within the PHCs, I think it was like a miscalculated step. So this is why actually we had the strikes and we had people not finding their medication in the pharmacies. So I think preparing the ground, and this is the behavioral change of patients, because patients actually, they were going to primary healthcare only to have the medication and leave. So there weren't like this continuum of care, and the idea of having the prevention, the consultation, the radiology, and the needed medication so medication, it should be at the end of this circuit. And for Lebanese residents, patients, the idea, it's mainly the medication, to go get the medication. So I think awareness, public awareness, education, it's very important to contribute to this shift of perception of the healthcare in Lebanon. And eventually we shouldn't forget the tertiary care and secondary care, mainly emergency. One cannot replace the other. So we have hospital care, public hospital care, eventually that is underfunded. We have the increased number of uninsured patients. We have the inflation rates rendering the NSSF coverage, useless, using the old rates. So now many Lebanese, they are not hospitalized for emergency. They are resorting to self-medication, phone consultation, nearby pharmacies. And we are seeing this in emergencies. We have endless complications and errors. So primary healthcare, it's extremely important, and eventually to decrease the toll on public hospitals. But it shouldn't, in public hospitals also, it should be very important, with taking into consideration the huge lobbying of the political lobbying of private hospitals. Right. So yes, it's not going to be easy.
Yeah, Rouba, I think what you're saying is the medications in Lebanon were subsidized previously, and then suddenly the subsidies were lifted, and the prices of medications went up by tens of times, I think, if not more, of what their price was before. So people suddenly could not afford them. And then also public versus private, the public sector is very underfunded, and then if patients go to a private hospital, if it's not an emergent issue, they typically are not admitted if they don't have at least primary or secondary health insurance that would let them be admitted. So this is a big problem that's ongoing, and that's where the importance of primary care comes in, to prevent these episodes from happening and prevent people from ending up in emergency departments that they cannot afford. And Vlad, as part of an NGO yourself, I mean, you're on the ground, right? And so what do you think of this plan that's ongoing at this point for primary healthcare?
Well, I think one idea that really pops out of Rouba's comment right now is, to actually let people know, that there is not only a possibility of having a medical consultation, but also, to actually follow up on your chronic disease, for example. Like, as you know, the non-communicable disease burden in Lebanon and worldwide is the biggest health burden. And what we end up seeing is the complication of non-followed up upon diabetes cases or hypertension or cardiovascular cases. So I'm also seeing that there is a will, and for example, 2 weeks ago there was a launch of the new PHC guidelines, with algorithms so that medical doctors could follow up, on the latest recommendation of clinical care. and you have partners which are most likely health international NGOs that will help, our local partners to implement those algorithms. So as Rouba said, the means are not there. The will and the complexity of thinking and the talent at the Ministry of Health is there. We always talk with them. They always have ideas. They always have new, out of the box suggestions. But yes, I mean, this is a small picture of a whole movie that that you need to develop and you need to work upon. And unfortunately, as Madhuri said, we cannot really look a long way into the future in our current state. So it is also hard for us. Like the IRC, we work both in humanitarian and development, world, and it is hard for us to get funding, to something in development, especially for a case like Lebanon, because it is not highly volatile, but unpredictable. It's unpredictable. You can never know when something can go wrong, or so we are all, doing our best to help, the people in need, and those people are growing and growing in number, So also we need to, NGOs, people, and people, by people I mean normal people who work or not in the healthcare sector, to let others know what is happening in Lebanon, because what I get whenever I travel, people come when they know that I'm a Lebanese doctor. They come to me and say, "Oh, hey, we don't hear about Lebanon in the news anymore. So the situation is good there, So the fact that there's no news internationally about the situation in Lebanon makes things also harder, which this, podcast will contribute to, to showcase, at least to the professionals who will be listening to that no, the situation is not okay, and there's a lot of talent and people who are working to let that health sector not sink, and keep it afloat. So yeah.
Right. I agree. And so one, I think, and I'm sure the Ministry of Public Health hopefully is keeping tabs into outcomes, let's say, of chronic diseases before and after implementation of some of these initiatives that they're implementing with the NGOs and with the donors at this point. And I have one final question, because we're running up on time at this point, but one final question is, which is very important, I think, because when you hear the news now in Lebanon, like everything's being blamed on the refugee crisis and the Syrian refugees, and they're taking up resources and they're taking up most of the donor funds and stuff like that. So do you guys have numbers as to how much or the donor funds, what percentage of them is potentially benefiting the Syrian refugees and what percentage of them is benefiting the Lebanese? And are the numbers going more to one direction or the other at this point? I don't know if Madhuri wants to start and then Rouba comment on that.
Sure, I can start on this one. So basically, I mean, I think, yeah, it's a very pertinent question, because as you mentioned, it's all over the news. And I think a lot of it is, perceptions and assumptions that need to somehow be debunked with facts and figures and what's really happening on the ground. So again, I'm not hiding the fact that the EU did become involved in the health sector initially because of the Syrian refugee crisis, and when we did become involved in the sector, the overarching idea behind the programs was that we had a 50-50 beneficiary group in terms of Syrian refugees and Lebanese host communities. And I have to say that within the health sector, because we targeted primary health, it was easy to implement, right? Because maybe, for example, if you look at the education system, you have what is called second shift school. So you have the Syrian kids are actually going to school after the Lebanese kids in the morning, right? So it's like a different system for the Syrian refugees. Whereas in health, because we're targeting primary healthcare centers and we're funding centers based on the number of people that they visit and they provide services to, we made no distinction to like, you can only support Syrian refugees or only Lebanese. It was like, support whoever needs support, and then you report to us at the end of the month or at the end of the quarter in terms, for us to know how many Syrians were benefited and how many Lebanese were benefited. So initially it was a 50-50 target, let's say. Of course, in some areas like more remote in Bekaa, in Akkar, where there's maybe a higher density of population of where Syrian settlements kind of started, there were more Syrian refugees that were benefiting, but in other urban areas like in Beirut and Mount Lebanon, it was a higher percentage of Lebanese going. Again, we were in a context in which there was a perception that primary healthcare centers were for vulnerable people and poor people, and Lebanese people who had insurance would just go to their general GP, pay for their consultation, have an insurance scheme to reimburse them. Now that, even Lebanese people don't have as much access to private care than they did, but they have access to these primary healthcare centers, we definitely see a shift where it's in some areas actually like 70-30% in terms of Lebanese people attending rather than Syrian refugees or accessing. So over the last few years, we've seen a percentage increase, and it's like an accumulative increase in the number of Lebanese that are attending to primary healthcare centers that are supported by us. Of course, we have access to data on centers that we are funding because there's a reporting obligation there, but the same trend is observed across the sector, and we know this given the sector coordination meetings that Vlad is mentioning and the updates that are given on a quarterly, monthly basis, and the response plans that everyone is working in. So on that front, 100%. I mean, in terms of primary health, we always had an easy way of accessing both populations because nothing was ever earmarked to a specific population. And then in addition, because there is this reporting, we see also in terms of medication. I mean, as Rouba mentioned, with the removal of the subsidies, more people are now going to primary healthcare centers to have access to their medication, especially that of chronic disease. And there, it's clearly more Lebanese people have access to this than Syrians. I would add one thing, which is probably a challenge for us, is to basically not once, if Lebanon were to all of a sudden be out of its crises and people were to have access again to insurance companies and specialized care or whatever, I think it's important for us to basically capitalize on the fact that now you have an increasing number of Lebanese people that are going to these primary healthcare centers. They're seeing that they can get quality health services there. And so a challenge will be to basically keep them in these primary healthcare centers and make sure that they continue to use preventive care and promotive care, which is relatively cheap, and even in terms of payment, because essentially the care that is provided at primary healthcare centers is much cheaper than that of tertiary. So basically, how to continue this incentive and this behavioral change and keep it. So keep this externality that has come from the crisis so that Lebanese people feel comfortable and taken care well enough to continue to go to primary healthcare centers even once the crisis is over, if it ever is over.
Rouba.
Okay, so maybe to complement what Madhuri just said, so for us, actually, we have never had like a target within our projects. We are always asked, okay, how much percentage Lebanese Syrian? We have never had a target. For us, it's the only principle, it's the do no harm principle. So it's only the vulnerability assessment. And this vulnerability, it's not only financial. Sometimes when we talk about mental health, it's more like cultural and social vulnerability. So for us, it's only really solely the vulnerability assessment that our partners can do in order to offer more equitable and quality healthcare health services. So the idea, we have witnessed the same shift. So as the project started before beginning of 2019, before the crisis, it was like the percentage, it was more like 70. It depends from the region, but for example, in the north, it was mainly also 70% Syrians and the 30% Lebanese and others. And now actually we are seeing this shift. We are almost at half, 50-50. And in some regions, we have more Lebanese than Syrians. And here it's very important because if you see and compare the numbers, then you will have 70% Lebanese, 30% Syrians. And you may assume that Syrians are excluded from the system, which is not the case. It's just a matter of volume. So Lebanese didn't choose to go to PHC. This is why actually we are seeing this shift in number. But I mean, vulnerable Syrians are now even more vulnerable. And we have this huge middle class of Lebanese who shifted within this vulnerable class. So this is very important to stress on, and even to see a bit behind the numbers and not only see 70, 30, 30, 70. So just to finish, so for us, we see that this shift, this crisis, let's take the opportunity of it, and let's make of the crisis an opportunity to rationalize a bit the public sector, specifically the primary healthcare. Now it's an opportunity to reshape this the system with the ongoing social economic crisis of the country. So after years and years of dominance and giving priorities to the hospital and public hospital and tertiary care, I think it's the time to reevaluate the importance of primary healthcare in order specifically to maintain the safe environment. For example, we don't see the tension around the healthcare system like we see it in the education. This is what Madhuri said. Actually, primary healthcare, it's like really they have the trust of the patients. They are a place for healing, for reconciliation between Lebanese Syrians, and regardless of the nationality. So they share the same issues, the same daily difficulties. So the idea now, it's really to give back the legitimacy and the credibility to this public system, and to earn the loyalty and to retain the patients within the system in order to contribute to what we call, or a kind of social contract in Lebanon.
Equitable contract. And Vlad, do you see this happening? Do you see the shift happening on the ground in your experience in terms of Lebanese versus Syrians and access to primary care?
Yeah, so for IC, we work in the north, in Akkar specifically, and between 2022 and 2023, we sometimes see like 2 Lebanese patients for 1 Syrian, you know, and it is not only because people, you know, don't have anywhere else to go. It is also because we empowered the local community, you know, to actually come to the center, and then whenever they come, we go back to them and ask them like how their experience was, what they like, what they didn't like, you know, so we could, you know, rally this feedback to our local partners, and also encourage our local partners to get this feedback, and so on. You have, when you get this wheel going, you will, you know, accommodate your services based on the community needs, and this is what's most important here. So you are slowly building the trust of the community in the primary care system. Therefore, as Madhuri said, we are capitalizing, and we need to capitalize on this trust to stay there even before the crisis, you know, because we are people, and we are investing a lot in the clinics, not only in financially, but in time and effort, but also sometimes we provide repairs, sometimes we provide medical equipment, sometimes even structural changes to the health centers. So yeah, all of this is encouraging people to come more and more. And yes, we are seeing a lot more of the vulnerable Lebanese population to come to our supported health centers. So yeah.
Yep, yeah, thank you. I think we're up on time right now, and thanks to all of you for being on the podcast and for discussing access to primary healthcare in Lebanon in the crisis. And I think it's important. I think what we highlighted today is there's more and more Lebanese who are in need of healthcare services than ever before when they were able to access private services in the past. And there's a need for the Lebanese government to work in conjunction with the donors and with the NGOs on the ground to develop a good primary healthcare system to decrease the cost of healthcare and improve access of care to all Lebanese, which hopefully the Ministry of Health is doing. And the other important fact I think we highlighted is that the donors and the NGOs are trying to serve everyone and not only a specific subpopulation of patients in Lebanon. So thanks to all of you for being on the podcast.
Thank you, Dr.
Thank you,
Khalid.
Fahid.
So much. Bye.
Thanks.
Thank you.
Bye.
Bye.
Have a nice day. Bye bye.